Hello, my name is Aogán Muircheartaigh, and I'm going to present the case of management of acute piriformis syndrome in a multi-morbid older adult. A bit of background: piriformis syndrome is characterized by hip, buttock, and lower limb pain caused by abnormal compression or irritation of the sciatic nerve as it passes through or under the piriformis muscle. Local anesthetic infiltration of the muscle can dramatically relieve symptoms, which can be considered a diagnostic sign. Analgesia from a single injection can last weeks to years. In our case, an 86-year-old lady with mild cognitive impairment, vitamin B12 deficiency, an abdominal aortic aneurysm, and severe coronary artery disease was admitted to the hospital with a 3-day history of severe low back pain, right gluteal pain, and a new inability to weight bear, preceded by 2 weeks of low back pain. She had no history of trauma, and orthopedic review and imaging demonstrated non-operative degenerative disease of her lumbar spine and hips. She was treated using multimodal analgesia, including paracetamol, oxycodone, morphine, tramadol, pregabalin, gabapentin, naproxen, tapentadol, transdermal buprenorphine, and topical lidocaine patches. Multiple medication changes were required during her stay due to ongoing pain, poor sleep, and delirium. At baseline, she was independently mobile, and she was independent in her activities of daily living. She progressed poorly with multidisciplinary team input, who noted her mobility was significantly limited by right hip pain. She required assistance to transfer from bed to chair and a wheeled Zimmer frame with moderate assistance to mobilize. The patient was assessed by the consultant pain specialist, which demonstrated a positive straight leg test at 30 degrees on the right side, tenderness over the right piriformis muscle, and a positive piriformis test in the sideline position. Following informed consent, she then underwent an ultrasound-guided right piriformis muscle injection with 10 mL of 0.25% bupivacaine and 80 mg of methylprednisolone, with no complications and excellent analgesia immediately post-procedure. She required no further breakthrough analgesia during her stay and described an 80% improvement in her pain symptoms. 2 days post-procedure, she was able to mobilize 18 meters using a walking stick. She was discharged home a week later. This case report demonstrates the important role of an interventional pain procedure in a multi-morbid older adult, including reduced side effects from systemic medications, improved mobility and quality of life, and earlier discharge from hospital. I'd like to thank the patient for providing consent for a case to be submitted as an abstract and to be presented to this meeting. I'd also like to thank the other members of the team, nursing staff, and other allied health professionals involved in her care.